I would like you to meet one of our patients, Anna, who works in her family's optometry clinic here in Richmond, Kentucky. Her husband, David, is an optometrist in town. I'll let Anna tell you about the pain she had before we treated her. And today we're going to treat her, however, as a new patient.
When I initially came, I was waking up every morning with a headache. I had headaches throughout the day. Tylenol and Advil and things like that just weren't doing me any good. I had neck pain, I had upper back pain, and I slept very little. Since I've been coming, the headaches are very seldom now. My neck and upper back pain are gone, and I sleep so much better. And I seldomly have a headache, and my neck and my back don't hurt anymore. And I did this all without narcotics or scheduled drugs.
Anna, could you describe your pain as pulsatile, meaning beating with your heart, okay, or burning, or constant, slowly throbbing?
More constant, slowly throbbing.
Okay. How many headaches do you have each week?
Oh, well, I wake up with one every morning.
Okay, so
And
7
then-
days a week.
Oh, yeah.
All right, and then in the afternoon they return, or,
Yes.
okay. Do you have tightness or pain when you turn your head or neck?
Yes, some.
Okay. Let's talk about the way you sleep. Do you have trouble going to sleep?
Yes.
Okay.
But mostly I can go to sleep fairly well. I wake up during the night, and then I can't go back to sleep.
Okay, so how many times do you wake up?
Oh, I'd say 2 to 3.
Okay. All right. Do you awaken refreshed or tired?
Tired.
Tired, even though you think you've got the number of hours you need in?
Yeah.
Okay. All right, let's go over here and let's go to a page where we're going to color in your pain.
Okay.
Now, I don't really care what you think causes the pain. Just if you have regular pain there, that's what we want to know.
Okay.
Okay? Do you have pain above your eyes?
Yes.
Both of them?
Yes. It's all the way across my forehead.
Okay. All right, do you have pain in your temples?
No.
No. Okay. The back of your head?
Yes.
Both sides?
Yes.
Does this pain run down your shoulders?
Yes.
You have pain behind your eyes or in your eyes?
No.
Okay. Any ear pain?
No.
No. Pain on top of your head?
Very seldom.
Very seldom. Okay. Any jaw pain?
Yes.
Both sides or one side?
No, just one side.
On the left?
Mm-hmm.
Okay. Okay, does this kind of look like you?
Yes.
All right. All right, so that's the usual day-to-day Anna Coleman.
Yes.
Okay. Anna, what we're going to do now is to squeeze some muscles. We call this palpating, which is the fanciful medical term for squeezing. Okay, what we're interested in, okay, is does the muscle hurt? Is it sore when I squeeze it?
Okay.
Let's try to use your arm as an example. Okay, does that hurt?
No.
That doesn't hurt when we squeeze it. Okay. If I hit you there today and then I squeeze tomorrow, it would be sore, and that's what we're looking for.
Okay.
All right, let's come up here now. Is that sore?
Yes.
Okay.
Yes. Yes. Uh-huh.
Yeah.
Yes, that's sore. Yes.
Okay. Anna, what we're going to do next is put the chair down
Okay.
and then take a look at your bite.
Okay.
So let's take your glasses off.
Okay.
All right. Okay. Now, what we're going to do here now is to take your jaw joint and put it up in the socket. Bring your teeth together till a tooth touches and then stop.
Okay.
Now, we close a little bit here and the tooth touches there.
Mm-hmm.
But your teeth are not meshed.
No.
Okay. Now, squeeze. Now your teeth are meshed,
Mm-hmm.
but what happens to the jaw joint? Well, it has to be out.
Mm-hmm.
So if we go back and we put the jaw joint in, then the teeth can't mesh, and then squeeze. Then if we squeeze and we mesh the teeth, the jaw joint's out. All right? So we can't have the jaw joints in and the teeth mesh simultaneously, and that's one of the things we need.
Oh, okay.
What we're going to look at here is we're going to relook at Anna, and we're going to look at Dr. Travell's book showing the trigger points and where the pain is referred to. When we go to this first picture right here, we see that this is the back of the head and that the trigger points are referring and causing pain up in this area here in the back of the head and along the shoulders. If we go over here and look at Travell, then we see the trigger points, and lo and behold, the pain is in the exact areas that we had for Anna. The next muscle we're going to talk about is the sternocleidomastoid muscle, which extends from behind your ear down to your chest bone, and it refers pain to the top of the head and above the eye. Okay, now let's go over to Anna, and what do we see? Well, we see that Anna has pain above the eyes and on top of her head, and then if we'll remember back, the sternocleidomastoid muscle was sore when we palpated. The final muscle that we'll go over today, knowing that there are 666 muscles in the body, and we're not going to try to cover them, is the masseter or jaw muscle. And in here in the jaw muscle, we could see that it may be part of the pain above her eye because these trigger points in the jaw muscle or the masseter muscle refer pain above the eye. They also refer pain to the tooth. So you could go into the dentist and say, I've got a toothache, and he could look and say, I don't see anything wrong, and you're both right. You have a toothache, but the pain's coming from the muscle, not from the tooth. Now, we've seen Anna, we've seen where the pain was, we've seen that, we started in April, we were basically good and out of pain for the most part within a couple months, and the pain went down initially within the week. So we want to titrate or so forth Anna's sleep medication, and we want to try to get her off of all the medications, and we've done that for about a month, and she's doing quite well and will. Will she have some setbacks? Sure. Okay. She'll have a setback every once in a while, but it's never are we going to go down to the weekly headache or a headache every 2 weeks even. All right, what we'd like to do now is to kind of present this with some visual aids so that you can understand the bite and where the trigger point acts up with the bite and then where the pain shows up. So let's take the stool, and a stool needs 3 legs on the ground to be stable. Okay, so what I want you to think about here is I want you to think about the 2 jaw joints as the back 2 legs of the stool and the teeth as the front leg of the stool. So back 2 legs, teeth. So in order for the stool to be stable, then all 3 legs have to be on the ground at the same time. Now, if we remember that when we looked at Anna's bite, we could have the jaw joints in the socket and the teeth not meshed, or the teeth meshed and the jaw joints out of the sockets. Now, what this created then was no stability. It would be like going over here to the stool, and let's once again, the jaw joints and the teeth. So we could either have the jaw joints in and the teeth not meshed, or the teeth meshed and the jaw joints out. Well, with her bite, this is what we get. So the only stability that is brought to the stool is that of the muscles of my hand. And when they get tired, then they're going to get in pain. If I happen to have myofascial pain, they may hurt up here, but the problem be here. So what we need to do is to get all 3 legs of the stool on the ground at the same time. All right? So what do we need to do? Okay, let's do this. Okay, that works for the stool. Okay, let's go over here to the jaw joint. So we have the jaw joints in, and the teeth can't mesh, and the teeth meshed, and the jaw joints out. And what we want are the jaw joints in and the teeth meshed simultaneously. So we don't want to mess with the teeth themselves, so we make a splint. And now with the jaw joints in, you see that the teeth all come together. And then with the splint out, we're back right where we started again. We're going to look at the different muscles that are affected by this. The first thing I think we should do is to try to look at the first chewing muscle as mentioned in Dr. Travell's book, and that's the trapezius, and it's this big back muscle. Now, it makes no sense how that's the first chewing muscle, so let's see if we can make some sense out of it. We know that a good bite is when the jaw joint is seated and the teeth are meshed. And Dr. Travell said that the trapezius muscle is the first masticatory or chewing muscle. Now, we know with Anna that when we put the jaw joints back, the teeth can't mesh. And when we mesh the teeth, the jaw joints are out. So let's see how that works. All right, so now what we're going to do is mesh the teeth, but it makes the jaw joints come out. And so what we have to do is tighten up on the trapezius muscle. And when we do that, we've got stability, but the stability, like my hand on the stool, is caused by the stretching and balancing of the back muscles. So what we need to do is to see what happens to these back muscles when we get the jaw joint and the teeth mesh simultaneously. So here's our splint, and let's put it in, and we see right away that the jaw joint seats, the teeth mesh, and the trapezius muscle relax. All right, let's see if we can put this together. We said that a good bite was when the jaw joint was seated in the socket and the teeth were meshed. Dr. Travell said that the trapezius muscle, this big back muscle, and the neck muscles were the first muscles to be affected by chewing. Well, that's really a long stretch. So let's see what happens. Well, we said, as we said before, a good bite was when the jaw joint was seated and the teeth were meshed. But we know in Anna that when her teeth are meshed, the jaw joint's out, and we come forward like this. So we've lost stability. So we have to gain stability, and where do we gain that from? Well, we gain it from the muscles in the back of the neck and the lower middle back. So we tighten these muscles up, and when we do, the head comes forward. But then what happens? Okay. Well, then what we have is that we start activating these trigger points because the only stability to the head and neck is brought through these back muscles. So the trigger points that we get, as we've seen before, are going to occur in the muscle, but then the pain is going to be referred as to a distant site. So what we need to do then is to see what happens when we seat the jaw joint and mesh the teeth at the same time. So let's let go of trapezius, and we see the head come down, and then let's put our splint in, which is going to seat the jaw joints and mesh the teeth. And when we do that, we take the pressure and the balance away from the back muscles and put it balancing between the jaw muscles in the front and the back muscles in the back. Let's see what happens in reality with an EEG's type of thing when we call an EMG, electromyographic. So what we've done here is that we've taken an electrode and put it on the patient's jaw muscle, and then we took another electrode and we put it on the back of the head. All right, so the jaw muscle on this graph right here in this chart is going to show up green, and the back of the neck muscle is going to show up blue. So we come along here and we ask the patient to clench. All right, well, when they clench, we see a rise or a peak, okay, in both the jaw muscle, which we would expect, but simultaneously we have a rise in the back of the neck muscles. So when we rest, both of them rest. When we clench again, both the jaw muscle and the back of the neck muscles contract. And this goes on very, very smoothly through the whole thing. In other words, what it's saying is that you cannot contract your jaw muscles without simultaneously contracting the neck muscles. We said also when we were talking to Anna that she took a while to get to sleep, and that she awakened 2, 3, 4 times a night, and that she dreamed a lot. So what we see here is that we're going to see 2 graphs. The top graph is the brain activity during sleep, and the bottom graph is the muscle activity during sleep. So when we start out, this red line is going to show us activity. This is low activity and high activity. So when we go to sleep, the brain activity drops lower and lower and lower until we get into stage 3 and 4 sleep. and then then the activity of the brain goes up into REM sleep. Now, simultaneously, the muscle activity, when we first go to sleep, is very high. Okay, and as we go through the different sleep stages, 1, 2, 3, 4, and REM, the muscle activity goes down lower and lower. Okay, so in REM, we've got a paradox here. We've got almost no muscle activity, but we've got a lot of brain activity. So what stage of sleep, if you're waking up 2, 3, 4 times a night, what stage of sleep would you most commonly awaken from? Well, you would wake up from a stage of sleep that had high brain activity. That's in REM. What happens when we do that? Well, we abort the REM cycle, and when we abort the REM cycle, we abort the muscle paralysis of relaxation, and we get to start all the way over here again. So we go into deep sleep, start going into deep sleep, 3 and 4, and then we get into REM sleep, and we wake up and abort the muscle relaxation. So this goes on all during the night, and you don't get to sleep very well. And what happens then is that you get what we call non-restorative sleep. So you go to bed tired, you wake up tired. Sleep is a very, very important factor in managing the headache and the neck pain. The primary reason that it is that we need to get the muscles and the whole body back to some restorative sleep. Restorative sleep means that you go to bed, you sleep well, you wake up, and you feel refreshed. What the headache patient does is they go to bed, they wake up frequently at night, they dream a lot, which is another light stage of sleeping, and they wake up in the morning just as tired as they were when they went to bed. So we call that non-restorative sleep, and it does not restore your body back to the place that it needs to go for another day. Let's talk about some nuts and bolts of how we treat this. The first thing everybody's going to want to know is how much does it cost and does my insurance pay for it? And the answer is yes, your medical insurance, not dental, but your medical insurance is we will be filing the claim with, and it applies to the same rules of it apply to anywhere that you go with deductibles and copays and that kind of thing. Before you leave, we'll let you talk to Linda, our office manager, who can explain that a whole lot better than I can. The next thing that I'd like you to know is that Anna's just one of thousands of people that we've helped. The success rate is in the 90 and above percentage. The success rate depends upon how much I listen to you and how much you listen to me. So this is a teamwork. I can't do this for you. You have to do it with me. So when you come into our office for the first time, you're going to have to fill out one of those long, boring history and examinations. And then we're going to take a panoramic x-ray of your teeth and your neck and your jaw joints. And then we're going to sit down to begin the examination process. We would really love to see you and help you with this. One of the reasons that I want to help so much in doing this is that I myself had a headache for 7 years. So you're not always coming to the office to see Dr. Ney. You're coming to the office to also see Jim Ney, the patient that had the headache for so long. I truly understand what you're going through. I truly sympathize with you, and more importantly, I empathize with you. The headache is terrible. It's terrible because none of the doctors can figure out what's wrong. Everybody says, well, it's just stress, honey. It's not just stress. It's a mechanical and a sleep problem that you did not cause that has happened, and eventually the muscles have gotten sore like they did with Anna, and we have to address the problems that we talked about, the bite, the sleep, and the muscle weakness, and a lot of other little things that come along that we have to manage. And our primary goal, and I say this very honestly, is to get you better, to get you back to yourself, to get you back to your family, to make you work better at your job, and for you to enjoy life.